This is so nice. You get to speak to everyone before we start.
Ma'am, Reena ma'am also has joined in.
Ah,
from
Reena
Salem.
ma'am, good evening. Yeah, of course, I know her. Reena
Hi,
ma'am, how are
Reena
you
ma'am.
doing?
So nice to have you
Hi,
with
Sonal.
us.
Hello, ma'am. How are you doing?
All good. Waiting to hear from you.
Wow. Now I'm nervous.
Hi, hi, Reena.
Hi, Yash.
Yeah,
Hi,
hi.
Deepthi.
Oh, Shalini is here. Shalini was with me in AB Shetty.
Hi, Sonal.
Hey, Shalini, how are you doing?
I'm fine. How are you?
Great, great.
All of us
All
are logged in just to listen to you.
see, I think let's just chat and go home.
Yeah, that would be nice.
There are so many people. Oh, Dr. Om Prakash is also here. He was here even for Gyan. Sir is really interested in
Very good
TMG.
evening.
Good
Very good
evening, sir. How are you doing?
Very fine, ma'am.
I'm so glad you came for Gyan, sir.
Yes. I wanted to see basically. And basically, this periangular incision, no, I had never seen before, periangular.
Acha. Okay, sir. Right. We do the high submandibular. Abhay does the periangular. Periangular, I feel, is still a little too big. I just give a small. I showed it, no, sir. I think, yeah,
Yes.
I
On my
demonstrated
table
the
also.
high, sir. Yes. The finger dissection is nice.
Yes.
Okay, great. I'm glad there are so many people.
More persons will be joining.
Oops.
Very interesting.
This are they related isn't that much of an issue. It's basically I'll be talking about these three things separately also. Mainly separately, and then in the end, the relation. Akhilesh, it's 9 o'clock. Do you want to start? How many people do we have? I can't even see that.
Yes, ma'am. We'll start in 2 minutes, ma'am.
Hmm.
We have 47
Yeah.
participants, 48 participants right now. We'll start in
Okay.
1 minute.
Yeah, sure.
Sure, more of
Vice President has joined in, and he'll just welcome the gathering, and then we can start.
Yeah. Yes. Anytime.
You have got cough.
I have a cough. I'm sorry. Who's this?
Om Prakash.
Yes, sir. I have a cough. I have zero immunity and I have like big time infections in my hospital. So anytime there's some virus, they all come and sit here.
I think we can start, ma'am. I request Dr. Srijit, Vice President of AOMSIKerala, to welcome the gathering.
Hello,
Sri,
hi,
sir.
good evening. Good evening, one and all. Pleasure to meet you all. People joined and more to come. Branches, international teams. I also welcome our shining star from Ahmedabad, Dr. Sonal Anchlia.
Thank you, sir.
Welcome,
Thank
madam.
you.
She is
Thank
heading
you
the
so
department in Government Dental College, Ahmedabad. And over to you, madam.
Thank you so much,
Ma'am,
sir.
sir, I need to introduce the moderator for the day. Our moderator for the day is Dr. Deepthi Simon. Is an associate professor currently working in GDC Kottayam. Madam has a keen interest in TMJ and related surgeries, and Madam will be moderating the session for today. I request Dr. Deepthi to introduce Sonal ma'am to all.
Thank you, Dr. Akhilesh. Thank you for having me on board. I would like to introduce today's speaker, Dr. Anchlia. She is the professor and head of the Department of OMFS, GDC Ahmedabad, and she's going to talk about TMJ, the internal derangements, subluxations, and the myofascial pain dysfunction syndrome. Are they related? That is what she's talked to us about. I'd like to borrow a quote from Winston Churchill. A riddle wrapped in mystery inside an enigma. I'm sure Dr. Sonal will agree with me. The more we learn MJ, I guess the less we know about it. But over to you, Dr. Sonal, and all the very best for your presentation.
Thank you so much, Deepthi. Thank you, Akhilesh. Thank you, Srijit. Thank you, AOMSIKerala State Branch, for having me over. And yes, Deepthi, as you said, TMJ is like so amazing. I feel it's just we just recently had Gyan, the 5th edition of Gyan at GDC Ahmedabad, wherein for 4 days we spoke about TMJ, only TMJ for 4 days, and we still felt that it wasn't enough. We still needed more time. So I only have an hour. Let's see what I can talk about it, and let's see where we go. Okay. What I'll be basically doing today is I'll kind of touch and introduce all the 3 topics, IED, subluxation, and MPDS. And then towards the end, maybe we can discuss about how they're really related. It's not like IED stands alone or MPDS stands alone, how these 3 are kind of interrelated and how we should diagnose and deal with them. Pardon me, I have this cough, so I'll be coughing from time to time. Okay, so all right. Now, see, generally when we see this kind of an X-ray, so what happened was, say, let's talk about this. That if this patient comes, generally what will happen is that generally most often people will say, "Acha, theek hai. There is this third molar. He says there is pain. I can't localize, but there is pain here on this side of the face. Acha, so there is a third molar. Let's remove. So maybe let's remove the upper third molar. Even though none of the third molars are erupted into the oral cavity, they are well inside the bone. This is, you cannot see this properly, but it's completely inside the bone. This is completely inside the bone. But a lot of dentists, not necessarily surgeons, but a lot of dentists would say, "Acha, if you have these impacted teeth, these are the ones that should be out first." So maybe, this tooth will be extracted, and then they'll realize, okay, maybe because it was too near the sinus, maybe you have an OAF. So then they'll treat the orovitral fistula. Then the patient will say, "No, I still have pain." Then they'll say, "Oh, you still have another impacted tooth. Let's remove this." Even though this is completely inside the bone, it is very near this canal. So maybe they'll remove this. Get the patient to keep the mouth open for a very long time, probably injure the inferior alveolar nerve over here. There might be bleeding. So overall, a lot of things, and then the patient still comes back to you with pain. And the reason is that maybe people have not really given enough thought to the fact that it's not only the teeth that can be causing facial pain, but actually a structure called the temporomandibular joint and things that are going wrong within the joint. I won't waste too much time on anatomy. We just know that, okay, EAC, external auditory canal, anterior to that, you have the glenoid fossa, the articular eminence, the head of the condyle, you have the disc, and above that is the superior, and then below is the inferior joint space. Here, posteriorly, the disc, where is this? Sorry, just a second. So posteriorly, the disc extends and then forms the retrodiscal tissues. Anteriorly, it is attached to the superior head and the inferior head of the lateral pterygoid muscle. This much we know, and we also know all the various muscles of mastication that are related to the face, the joint, and in relation with the MPDS. We know all the muscles, especially the masseter and the temporalis. And we know that auriculotemporal nerve is the main sensory supply to the TMJ. Let's stop the basic anatomy there. Now let's start with TMJ disorders. Now TMJ disorders collectively are used to denote a lot of clinical problems that basically have either the masticatory musculature or the joint itself or both. Anything to do with either the muscles or the joint or both are basically called TMDs. And this is the latest classification, where again that is what they've done, extra articular. So that is muscles of mastication, whatever is wrong with that. So it may be just a muscle spasm or myalgia or MPDS, tendinitis, or there is a joint issue in which the joint issue may be either inflammatory or there may be disc derangements, hypermobility, infection, inflammation. We'll come to this again. Now, what is the etiology? What happens that may cause TMDS? So it is either macro trauma, meaning direct, big time force, so maybe direct trauma to the mandible, or maybe an indirect trauma, which may be like, say, a whiplash injury, or that is actual trauma. Then you have micro trauma, when maybe you have maybe the patient has parafunctional habits. So when the loading kind of exceeds, there is a certain limit up to which the patient can bear the load. But when that functional limit is exceeded, then the degradation of the articulating surface starts. And then within the synovial fluid, there is a hypoxia and reperfusion theory, wherein there is release of free radicals, and that is what causes further damage within the joint. Or then it may be associated with some systemic disease. So etiology, so TMD is divided into two, either muscle or joint. The reasons may be either direct macro trauma, indirect micro trauma, or some associated systemic disease. Is occlusion really a factor? There has been so much written and said about it, but then towards the end of the day, minor occlusal problems don't really have any say in the matter. Now it's not really only occlusion. It has been replaced by psychosocial issues that are really the cause of TMDs. But then also, if you have something majorly wrong, one second. Yeah. Majorly wrong with the dental or the skeletal position, then yes, there might be some micro trauma that may exist. So again, it can either be muscle or joint. Now let us just rule out the CNS component. So if there is a central issue to the pain, let's just rule that out. So that once that is out, so maybe there is some sort of chronic pain or some neurological issue, maybe fibromyalgia or chronic tension headaches, all that. If once that is ruled out, then we are left with muscle and we are left with joint. So as we said before, muscle has a lot of things here, muscle issues, but let's specifically talk about MPDS, myofascial pain dysfunction. And then when we come to joint disorders, as we've said, it will either be internal derangement. We will deal in detail with all of these things. So either internal derangement or some sort of arthritis or inflammatory conditions or subluxation dislocation. Now, this is the book that has been written by AOMSI. And these are two very good chapters in the book, which I would recommend all the PG especially to read up, please. Baig sir has written the chapter on MPDS, and Gary sir has written the chapter on internal derangements. And I was fortunate enough to write an article about ID in India with Gary sir and Nehal in our own journal. So this is that article. Now, generally it is said that, we are, as maxillofacial surgeons, we feel, okay, this is the cure for this condition. This is the cure for this condition. For any sort of problem with the joint, it is better to say that we can manage the joint. To successfully cure internal derangement or successfully cure chronic pain in the TMJ is rather difficult. So generally, even to the patients, when we talk to the patients about this, we still say that we will try and manage your condition to the best. Now, how do we manage? Let us understand that we have to start with an accurate diagnosis. Unless we have, there are so many patients who say, there are so many surgeons who say, okay, the patient has come, pain is there, okay, either give the patient muscle relaxants or we'll do arthrocentesis. It can't be like that. It has to be, everything has to have a diagnosis, and only then you can proceed with the cure. And the diagnosis has to have an etiology. So you start with how did it start? What has it led to? And now that we have this particular diagnosis, how do we actually select the appropriate treatment? Now, any patient that comes to you with facial pain, he will have these three things: pain, there may or may not be joint noises, joint sounds, and there may or may not be loss of function. So these are the three things around which we have to revolve our history taking and examination. So now history, when how we start with any patient who comes in with facial pain is that, okay, so where is the pain? Now, generally the patient might say, okay, here, the pain is like this. Can you all see me and hear me and all? Okay, right? All fine, na? Akhilesh?
Yes, ma'am. Yes, ma'am.
Acha. So right now we're talking only about muscle, and then we'll come to the comparison of muscle and joint later. But still, so if the patient says, okay, pain here, so this isn't a particular point as such, pain here, and then, or the patient might say pain here. So if it's a finger point, then okay, the patient is like, he knows, and it is surely coming from the joint. If he says, okay, here, then it's like, okay, it might be pointing towards a muscle source. MPDS may not have it. See, MPDS and ID can coexist, in which case there'll be a muscle issue also and a joint issue. But let's talk right now only about muscle pain. So pain here. Okay. Now, what are the initiating factors? If there is a joint issue, there can be, big time trauma, or even if there is some trauma to the if the patient has eaten something really hard, there can be a joint issue, or the muscle may have gone into spasm. Or rule out the central part. So if the patient is saying that, no, I have pain here in the head, so that can be a chronic headache, or it might be something to do with the ear, or maybe the power of the eyes has changed. So all of those things also you're supposed to rule out. Now, if there are any joint noises, we will talk about that later. Again, if there is a joint issue, you need to ask the patient about whether there are problems in other joints as well. Are there any parafunctional habits? Is there any bruxism or clenching? So for that, you might not necessarily have the patient, sleeping with somebody at night. So you can check this, the parafunctional habits or the habits of bruxism by two ways. So you ask, okay, your pain, is it worse in the morning, or, during the day, does it get worse? So if it's more in the morning or more with stress, if it's more in the morning, the patient has clenched and has bruxed the entire night, and that's why in the morning his pain is worse. And then you have to ask that, okay, so has there been any treatment done so far? If the patient says, oh yes, I've been taking pain medications, and then I've been taking, say, ultrasound and stuff for about a year, then you can't tell him, Acha, now go back and then come back after 3 months, I'm writing more painkillers to you or muscle relaxants for you. So you also have to keep in account what treatment has the patient undergone thus far. Now, all of these things, yes, but most importantly, you have to, the minute the patient walks in, you have to gauge, is there some psychological effect in that patient as well? Mostly, see, there will be female patients, maybe, the younger age group, maybe the exam the exams have some stress going on, or there might be other things. So you have to gauge can there be anything psychologically wrong with that patient as well. And this cannot be done, right in the middle of a noisy OPD. So you'll have to kind of take the patient aside, talk to the patient about maybe, okay, Acha, where are you from? And so what do you do? Who is at home? All of that, and then gradually ask, Acha, bhai, is there any stressful thing? Acha, you're writing exams. Oh my God, do you sleep at night? Like that, you have to kind of get to know a patient directly. You can't ask, is there any tension? Acha, no tension, fine, okay, no stress. You can't do that. And then gradually these things will come out. So psychiatric history, psychological history is an absolute must whenever we are talking about any sort of ID/MPDS issue. So this pain, we saw those three things, right? So it is pain, how pain, everything about pain. Then let's just go back. Pain, joint noises, and loss of function. Is there any decrease in the mouth opening or increase in mouth opening? Whether it is normal, as in whether he is subluxing or reduction, and are there any joint noises associated with that? And what about the pain? When did it start? What kind of pain is it? When is it worse? Whether it's in the morning, etc. Now, since right now we're talking about muscles, let's just see that, okay, when we palpate the muscles, so this is the, obviously here when we are palpating, it is for the temporalis. When we palpate here, it is for the masseter. Look here at the lower end of the lower right-hand corner. This is for the masseter. Sternocleidomastoid, trapezius. So this way you examine the muscles. And then if the muscles are tender, you know, okay, there is definitely a component of MPDS. Now, whether there is a component of ID also or not, we will come to that again later. But you have taken the history properly about all those three things, and you have done the examination properly. Now, if you, with this much, if with your history and your examination, if you're sure that, okay, there is no component of CNS issue, or there is no component of joint, then this is how you have to go about it. It's only purely MPDS. So you educate the patient, tell them, okay, don't clench your muscles too much. So don't chew hard foods. Avoid opening your mouth too much. Avoid excessive talking, because you have to give rest to your muscles, and you have to avoid parafunctional habits. So try whatever, bruxism, if there is tongue thrusting, or if the patient is continuously biting on some objects, all that. This is how you educate the patient. And how do you treat the patient? Again, non-surgically for MPDS. So you can have you have NSAIDs. Principally, it is which tablet do we give? Indomethacin. Indomethacin that has shown to be very effective in treatment of joint issues. But here for MPDS, you would generally give muscle relaxants. Now, muscle relaxants are generally, you have chlorsoxazone, then you have tizanidine, and the latest that you have is thiocolchicoside. Now, the initial, these ones, chlorsoxazone and tizanidine cause some sort of hallucinative effect. So therefore, the best one is a combination of etoricoxib and thiocolchicoside. So that is what we give generally. Muscle relaxants. And if the pain doesn't go with that, then Botox injections, we will come to that later. Now, let's just come to this 1 second. Now, physical therapy, you have to give the patient isometric exercises, because the muscle is in spasm. You need them to be, there has to be training of the muscles, or muscle conditioning in the right. So you have to give isometric exercises. So you can refer the patient to a physical therapist, and they would give them exercises, or they would use some modalities such as ultrasound or TENS or low level laser. And not to forget is the stress reduction protocol. So it can be, you send the patient to a psychologist or a psychiatrist, or so that thing, if there is an issue, and generally you will find there is some sort of stress issue, so for that there has to be stress reduction. Now, lastly, what does occlusal appliance therapy do? Like there are n number of occlusal appliances which are being given, either full coverage or partial coverage issues, appliances. But generally what has been seen is, and there are a lot of studies about this, but generally what has been seen is that these appliances, it's not like that they will, get the disc. If the disc is displaced, they will not get it corrected. So all that they can do really is give support in the acute phase, or in the acute time when there is a lot of pain. That is the only time where they can, just because of the fact that they are disoccluding the jaws, that is why they are giving pain relief, just because the patient isn't biting on them. So basically what they are doing is they are providing crutches in times of emergency. That is all they're doing. They're only, it's like an ankle support or a back support, So they only give symptomatic relief during recovery. That is all that they do. They do not do anything else. So during an acute phase, to get rid of the parafunctional habits, for some time you can give occlusal appliances, but not for a long period of time, because they themselves can cause certain problems also. Botox, we will come to that again, but if not just lateral pterygoid, any muscle that has pain and that is not being relieved by only, say, physical therapy, physical modalities, or by muscle relaxants, then yes, botulinum toxin, different doses in different muscles has been used, and there is a lot of literature that says that you can use it, and it does provide good relief. Now, this is as far as MPDS goes. So first, again, those three things, right? Remember always, what type of pain? Is there any joint noise? And is there any loss of function? In these three things, you have to take the proper history and do the proper examination. Once you have ruled out the joint issue, you know completely it is only muscle. Then there are two ways of treating it. One is patient education. The other is those therapeutic agents or physical therapy and physical modalities. Psychiatric history, very, 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 very important. And then if it is not responding to that, then you come to Botox. This is our MPDS part over. Now let us come to the joint part. Okay. Now, I am not running the whole thing. We'll just quickly forward it and see. So we know the anatomy, right? Okay. So we know that this is our condyle, this is the disc, retrodiscal tissues, superior and inferior head of the lateral pterygoid. Okay. Now, this is the way it functions. In the normal way, TMJ, the disc is completely 12 o'clock position over the condyle and it moves forward with the condyle. This is when you have normal TMJ movements. And in normal TMJ movements, this is not moving forward, that generally about 15 to 20 mm is only rotational movements. So till 15-20 mm, it is only moving the rotational movement. And then as it goes forward, so beyond 15 to 20 mm, when it opens, it translates. This is the translational movement. That is why, so 15 to 20 mm in rotation up to here, and as it goes forward, it will translate, and then you will get your 35-40 mm mouth opening. This is normal. But now, suppose the disc is anteriorly displaced. Generally, more often it is anteriorly displaced. So now, if it is anteriorly displaced, then you know what happens is the retrodiscal tissues come anteriorly, right? Disc has gone forward, so now the retrodiscal tissues that were here have come above this, above the condyle, in the place of the disc. So now the disc is avascular, so there is no problem with that. When the disc is over the head of the condyle, then there is no pain. And the disc glides, as the disc glides forward, it is anteriorly displaced. Then the retrodiscal tissues, which have all the vascularity, which have all the nerve supply, they come in this place. So now the retrodiscal tissues and the nerve endings are between the glenoid fossa and the condyle. And here now there is pain. So this is the reason for the pain when the disc is anteriorly displaced. Okay. This is the pain, on the and then you will have inflammation of the retrodiscal tissues or retrodiscitis. Okay. Now what happens is, since the articular disc is anteriorly displaced, now the condyle is trying to, when it is moving forward, the disc is coming in its way, so it has to push against the disc and then open. Now there are two types of disc displacements. Either disc displacement with reduction, wherein the disc comes back to its place, to its position once the mouth is opened, or the disc does not come back to its place, it just stays there. It is anteriorly displaced, it will stay there. So what happens is, now in a displaced disc with reduction, what happens is the condyle is trying to open, and it is opening, it is pushing against the disc, and when it is pushing against the disc, that is when the patient is having a click. Okay, so the patient pushes against the disc, clicks, and opens. So when he opens, because the disc is reducing, so he is able to open, but there is a click. And then when he closes, again the disc slips back, so again there is a click. So there is an opening click and a closing click, but the patient is able to open the mouth because the disc is reducing. But when the disc is just lying anteriorly and it is not reducing, okay, so then what happens, look at this. So now what is happening is that it is just lying anteriorly and the condyle is unable to push it forward and unable to translate anteriorly. So what happens is that the mouth opening is now restricted. He will be able to get about 15-20 mm mouth opening because that is all rotation. But forward, further to those 15-20 mm, now the patient is unable to open the mouth. But since he cannot even push the disc anteriorly, so now there is no click. Okay, so now let's have the whole thing again. In disc displacement with reduction, there will be clicking, but the patient will be able to open his mouth. As the internal derangement worsens or as it goes forward, when disc displacement with reduction becomes disc displacement without reduction, then the patient will not have any click. He'll say, I used to have clicks, now I don't have clicks. But I used to open my mouth, now I cannot open my mouth because the patient is unable to push against the disc and open the mouth. Okay? Without displacement, clicking, but no restriction in mouth opening. Without reduction, sorry, this is with reduction. Without reduction, there is no clicking, but the patient can't open his mouth either. Okay. Just quickly, this is a cadaver section. This is available on YouTube or on the internet. This is the cadaver. So this is, more of a live thing. As in, you can actually see the disc looks like this, okay? Posterior band, anterior band, intermediate zone. This is how it moves forward. This is normal. Now, okay. With reduction. So now the disc is displaced anteriorly, but when it is moving, when the condyle is moving forward, the disc is coming back. Now again, it is going back. You see, it is displaced anteriorly. You see the click, opening click, and now this is the closing click. Okay, it has gone forward again. But when the patient opens the mouth, it reduces. Okay, this is with reduction. Then you have this displacement without reduction. So the disc is lying anteriorly here. See, he's trying to open the mouth, but he can't. Disc is lying anteriorly here. Opening, opening, opening. No click, no opening. Okay, but because the disc is just refusing to move from here. Yeah, this is disc displacement without reduction. Now we're talking about joint, remember again, okay? We're talking about joint internal derangements. Now they can either be just sada wala internal derangement, or it can have certain other, arthritis or other issues with it. So you rule out all of these, say RA factor and HLA and ANA, to rule out other issues because of which the patient may have joint pains. Sorry. Okay. I'm repeating this, especially for the PGs, because this is really important. You can't not know what internal derangement and what disc displacement with reduction is and without reduction is. Okay, so this is it. Now, if you remember this examination, we have already done the examination for muscles. Now, I've put them in separate zones, okay? But if a patient comes to you, it's not like you have to examine only muscles and you have to examine only joints, okay? You have to examine muscle also and joint also. So now that we finished the muscle examination, that same patient now we are examining for the joint. So what we have to do is, in front of the ear, we examine the joint for whether there is any swelling, any obvious swelling, any tenderness when you're palpating the joints. How much is the movement? So how much is the mouth opening with pain? Without pain, and then with pain. So hinge movement and translatory movement. Is there any sort of is there, when the patient is opening the mouth, is it absolutely symmetric movement, or is the jaw deviating to one side? Is the patient, how much, first and foremost, how much is the mouth opening? So what people do is they'll say, okay, this displacement with reduction, without reduction, this, that, but they haven't noticed that the patient is opening the mouth 50 mm, so he is subluxing also. So there are three or at least two components here. There is subluxation, and with the subluxation there is a component of the disc displacement also. So that is something that you have to see first and foremost. How much is the mouth opening? And then you see all of these things: pain, how much is the hinge movement, how much is the translatory movement, whether there is symmetry of motion or is it going onto one side. Are there any clicks or crepitations? If there is, say, if the patient, if it has really proceeded to degenerative joint disease, if there is arthritis and all, you'll be able to feel those crepitations inside. What type of click? Is it an opening click or a closing click, or is it the whole condyle that is moving? So it's not really a click; it's like a big clang. The entire, if it is subluxating, it is the entire condyle that is moving in front of the articular eminence. It's not just a small click which is due to the articular disc. We've never really used to check the joint sounds, but you can. Okay. Then all the entire range of motion. Is there any limitation in any range of motion at all? Whether it's opening, closing, left excursion, right excursion, protrusion, all of those movements you have to note down. Now, this is the most important test. Okay. So now, as of now, till now, what you've done is you've taken a proper history. You've done proper examination of the muscles. You've done proper examination of the joint. But you're still not sure. The patient says, either be here also there is pain, here also there is pain, here also I'm not sure where there is pain. Okay, so then is the pain coming from the muscle or from the joint? Now we have to be sure it is either this or that or both. Only then, so therefore, unless we have a proper diagnosis, we can never be sure as to what kind of treatment to do, right? So you have to be sure whether it's only muscle or only joint or both. So now to see whether the pain is from the muscle or the joint, this is the test that we do. It's called the bite test or the Mahan's test, wherein what we do is we put these two ice cream sticks on one side, okay? One side molars, if the patient is biting on one side molars, and if the pain is on the same side, that means it is because of the muscle. The muscles are being used and the muscles are paining, okay? So if the pain is on the same side, it is because of a muscle issue. If he is biting on the right, but the pain is on the left, so that's the opposite side joint that is being loaded. Therefore, the joint is the problem in this case and not the muscle, okay? So if it is same side, you put the ice cream sticks on the left side and the left side only you have pain, that is because of muscle. If sticks on the left and pain on the right, that means the reason is because of the joint. The pain is because of the joint. Okay, and for signs of parafunction, you have to see whether there is tooth wear or there is a restoration which has fractured or there is scalloping of the tongue. Okay, occlusion, if it's like really bad occlusion, yes, it can have a bearing on ID. So if there is open bite or there is cross bite, there is midline deviation, if it's like really bad, say Angle's class 3 skeletal relationship, all of that. Okay. Now, suppose still you've seen all of these things, okay? Your history is done, your examination is done, your Mahan's test is also done, and you're still not sure. Okay, but is it joint or is it muscle? Somebody's microphone is on. Can you switch it off, please? Somebody's mic. I don't know whose is on. Okay. So where was I? So now you're still not sure, huh? You've done history, examination, and Mahan's test you've done, and you're still not sure. Is this pain coming from the joint or from the muscle? Then the last test that you can do is give a diagnostic block. So you give an auricular temporal nerve block, and if the pain goes away, then you know that, okay, yes, now my pain is definitely because of the joint. Obviously, any muscle pain will not go away with auricular temporal nerve block. Okay, so these are the ways to distinguish between whether there is a muscle pain or a joint pain or whatever. And then you can have, say, you put those ice cream sticks on the right side, you have right side pain also and left side pain also. It means that you have muscle issue also and joint issue also. Okay. Or what you can have is probably you put on the right side the sticks, you have pain on the left side, so you know, okay, it is joint. But then when you put the sticks on the left side, then you have pain on the left side only, so then you know you have left joint and left muscle. Okay, I hope I'm clear. Now I'm repeating this a lot of times because no matter how many times we've talked about this, there are still so many people who are like confused about this. So, and then if there are any bony issues, obviously we all know this. So say maybe arthritis, or if there are any loose bodies that are to be checked, so then you need CT scans. And for better visualization of the disc, then it is the MRI. Now MRI in the closed mouth position and in the maximum open mouth position. These are the two types of MRIs that we want to take. And T1 weighted images and T2 weighted images. So now see here, this is the condyle. Okay, the disc will not be white. Okay, this black thing, this is the disc. Okay, this is the glenoid fossa here. This black thing here is the disc. Okay, this is normal disc position from here to here. This is the condyle. This is closed mouth position. As the condyle moves forward in the open mouth position, the disc comes with it. Okay, this here, a bow tie shaped structure, is the disc. This is normal. Now, suppose the disc is displaced with reduction. We have to know, guys, we have to know how to read an MRI for the disc. Okay, you cannot rely on the radiologists. So now this is a closed mouth position. In the closed mouth position, this here, this is the disc. So this is lying anteriorly. Closed mouth lying anteriorly, means it is definitely anteriorly displaced. Now whether it is reducing or not reducing, you will know only when the patient opens his mouth. So now the patient is opening his mouth. When he is opening the mouth, the disc is coming directly over the condyle. Okay, so this means that yes, the disc is definitely reducing. And then when he closes his mouth again, this black thing here, this is the disc which goes back anteriorly. Okay, so anteriorly in the closed mouth position, then in the normal just above the condyle in the open mouth position, as when he closes the mouth again it goes back anterior. Okay, so this is disc displacement with reduction. Okay, then you have without reduction. So this is closed mouth position. You have this crumpled thing. It's not even a bow tie thing structure anymore. Crumpled thing lying anteriorly, closed mouth position. When he tries to open his mouth, the crumpled thing is still anteriorly crumpled only. It's getting even further crumpled. Okay, it is not coming back to the normal position above the condyle, below the articular eminence. It is not coming. Therefore, this is without reduction. Okay, disc displacement without reduction. So here there will not be any clicking, plus the mouth opening will be restricted because of a mechanical locking of this condyle because of the disc for it to move forward. Okay, because the disc is sitting there, it's saying no boss, you cannot go any further. And in T2 weighted images, you'll be able to see some amount of disc joint effusion also here. So there is so much of inflammation that there is joint effusion also. I am 40 minutes into this lecture. Okay. This is done. Sorry, this is repetition. One second. Okay. So now, based on the clinical and the radiological findings, Wilkes was the first guy who said, okay, let me classify all of this. So now this is just too much. On the left, it's just too much. But basically, he said, okay, according to the stages, according to the clinical and the radiological findings, you will classify them into stages 1, 2, 3, 4, 5. And then based on that only, you would decide what treatment is to be done. So this is something that, guys, you will have to read up. Okay, initially, obviously, stage 1 is like, okay, it is disc displacement, then disc displacement with reduction, then disc displacement without reduction, and then finally there is arthritis also, and the disc has got perforated also, like that. Okay, so please read. But as the stages go on further, the halat of the joint becomes worse. And now there is arthritis. So we spoke about this, right? There are certain things that you need to rule out. Okay, certain other serological tests that you need to do to rule out other reasons for arthritis. And if there is arthritis or end-stage joint disease or degenerative joint disease, then there will not only be tenderness, there'll be crepitations, there'll be loss of joint space. All of these things you'll be able to see in DJD. So condylar flattening, osteophytes or erosions of the bone, there'll be subchondral small cysts. that will be visible, or there may be heterotopic bone formation. And in this kind of stage, then there is nothing that your arthrocentesis or arthroscopy, etc., will be able to do. Here, you'll have to go in for a joint replacement. We'll come to the treatment in a bit, but basically, this is like the bad thing. Okay, initial stuff is disc displacement with reduction, disc displacement without reduction, perforations, and then degenerative joint disease. Like that it goes. Okay, so till now we've understood everything about how to diagnose muscle, how to diagnose joint, how to do non-surgical muscle also. Now, how do you decide, okay, now boss, we need to do something surgical about this. So now surgery is only for symptoms or only for patients who have symptoms originating from the joint itself. So the pain has to be localized to the joint, there has to be tenderness over the joint. Then the Mahan's test has to be positive. There should be an effusion on the MRI. The diagnostic block has to be positive. MRI, CT scan, everything, you should be able to see that, yes, there is a definite problem. Or if you have a closed lock or an open lock, closed lock is because of the disc which is not reducing, that is the closed lock, the patient cannot open his mouth. Open lock is when the patient has dislocated and cannot close his mouth. So okay, I would need another 10 minutes, I think, Deepthi. Is that okay?
Yes, Sonal, you have all the time in the world. Carry on.
Okay. All right. So now this is a pyramid for the surgical management. So initially you start with small little things. You start with arthrocentesis, so minimally invasive stuff, arthrocentesis. Then you go on to maybe arthroscopy. If that, then with arthroscopy, you have level 1 arthroscopy, then 2 and 3. We'll come to that. If that doesn't work, you keep proceeding further, remove the disc, or then you remove the joint itself. We'll come to what to do when. Now, is it absolutely essential that the disc and the condyle have to be in correct place? Well, no, because there was this huge study done on some 2000 plus patients, normal asymptomatic patients. They said, okay, come, let's just do an MRI on you. So there is no symptoms in those patients. But on the MRI, at least 30% patients in those asymptomatic guys had disc displacement, which means that even if your disc is displaced, it doesn't necessarily mean that you have a problem, because the TMJ is something that adapts. Okay, so what happens is the disc will be displaced, the retrodiscal tissues will take its place, but in the process of still opening, closing, whatever, that these retrodiscal tissues will then become fibrosed and form something known as the pseudo disc. So in 30%, at least 1/3 of all of us, we still may have a bad joint in terms of the disc being wherever, but we may still not be symptomatic. Okay, so the problem is not in the position of the disc, the problem is in the mobility of the disc. So wherever it is, it should still keep moving. If it has adhesions, there is a problem. If it is stuck somewhere, there is a problem, and among other things. Okay, so it is not necessary that if you see an MRI and if you see, okay, this is displaced, I have to, if I do scopy, then I have to do a level 3 arthroscopy and pull it back and take sutures and whatever. And if I don't know how to do scopy, chalo joint, open joint surgery. Not in all cases. Only if there is clinical and you definitely see a lot of other things in that patient, then yes, the patient is indicated for surgery. Okay, now I don't think I need to go too much into details of this. Now this, we know the line, and then we know this is all that's been done, right? Arthrocentesis we all do. So it's the only thing that's different here is just that instead of 2 needles, where we're doing it only with 1 needle which has been shouldered together. So just 1 prick and 1 prick, and you're putting the RL through one, and the other needle is the RL is coming out. So that's the only difference. Okay. All right. Now this also we've spoken about earlier. So we do a level 1 and 2 arthroscopy. We will come to that. What is the meaning of that? So we do a level 1 scopy, which is only basically a diagnostic scopy. Level 2 is when you're taking some amount of material for, say, biopsy or mobilizing the disc a little. That is a level 2 scopy. Level 3 is when you do an arthroscopic discopexy. When you have the disc anteriorly displaced, you pull it back and tie it with a suture. Okay, so those are the 3 levels of arthroscopy. So you finished your level 1, you see, okay, there is a problem. You go do a level 2. take a biopsy, you see, yes, the disc is displaced. Okay, you do a level 3, get the disc, mobilize the disc, take it back. Okay, and you still feel that the disc has gone back, or there are perforations in the disc, or there are problems in the bone, then you have to open the joint and replace the joint. So then we are talking about total joint replacement. Okay, level 1 to 3 scope, maybe arthrocentesis, level 1 to 3 scopy, and then TJR. That is how you go. So it's like all treatments have a ladder. You don't directly say, "Arey, boss, your joint doesn't look good. Chalo, let me do a joint replacement." So it doesn't go like that. It has to be like this. The problem with arthrocentesis and scopy is that, okay, arthrocentesis didn't work. Okay, maybe arthroscopy also didn't work. The difference is that in arthrocentesis, you are kind of nowhere. You don't know, okay, what is the problem? So now what do I do? In arthroscopy, at least you've actually seen inside the joint. So you know, acha, what is wrong with the joint? Now I know what I have to do. Okay, now I don't think there is time to show you all this, but quickly. Okay, so first what you have to do, this is scopy, okay, level 1. Palpate exactly, pull the mandible anteriorly, palpate where exactly is the highest point on the glenoid fossa, that you have to mark. Okay, and then insufflate first, so mark that point. Okay, take a needle with local anesthesia. Insufflate, as in this, in the superior joint space, you put in at least 2.5 millimeter ml of local anesthesia. Okay, here, see, when you're coming back, you know that, yes, this is the synovial fluid that's coming. And then when you push in, this is the synovial fluid that's coming out, or the local that is coming out. Now, when you're pushing and you're pushing, you'll get a black, can you see the plunger coming back? Okay, that is the back pressure. That means your superior joint space is full. So now you take your sharp trocar. You are increasing the size of the up superior joint space. Now you take your sharp trocar and then touch the arch. And while touching the zygomatic arch inferior border, then you go dip down and then enter the superior joint space. Okay, so this is about 20 to 25 mm. Then you connect the saline. Vacuum effect is when you open the mouth, close the mouth, then that is creating a vacuum inside, so that you can know that, okay, yes, whatever you've injected is all coming out. Connect the water to it. Flush the joint, because there'll be some blood and some whatever. So flush the joint, get till such time the entire joint is clean. You're flushing the joint with the water, or with the RL, saline, whatever. Okay, that's known as backwashing. And then you put in the scope. Okay, now this is the scope going in. All right, once a scope goes in, quickly see whether you're inside the joint. And then you need the outflow needle. Okay, so push water and your needle, and this comes out. Okay, outflow needle, 5 mm anterior, 5 mm down from the initial puncture. Okay, that is it. That is your level 1 scopy. You are inside the joint. Now these are the 5 things. Maybe I'm on a webinar. The 7 things that you have to see when you enter. You will be entering the superior joint space, but posteriorly. So no, I need this. Sorry, 1 second. I need this, baby. Okay. So when we enter, this is the oblique protuberance. Okay, and the medial synovial drape. As we go inside, this is the lateral pterygoid muscle, or the shadow of the pterygoid. So this is the pterygoid shadow. Then we come out a bit. Okay. Now you look up. This is the when you're looking up, this is the glenoid fossa. Okay. Go further anteriorly. This is the intermediate zone. White on white, intermediate zone. That red thing that you saw was synovitis. Going forward. As you go further forward, lay the arthroscope flat. Then we see the anterior recess. Okay, anterior recess. See that much? And your level 1 scopy is done. And you're seeing certain fibrillations here or adhesions here. Okay, level 1 done. Now, go level 2. Now, see, level 1 is you have the scope and you have one more entry. Okay, so basically it's just one cannula. Now here you put in another cannula. So if you see that, okay, there is a certain, when you see level 1 scopy, you are seeing, okay, there is a fibrous band in the anterior compartment. Okay, so now you want to go in and remove that fibrous band or cut it off. So what you have to do is you do a triangulation technique. So how much ever you have gone inside here, just anterior to that in the same line, you mark the same thing. So if it's 20 mm here, you go 20 mm there also. Mark that, I'll show you. Mark that, put in another needle. Okay, that is the triangulation technique. And then this needle you can see coming in through the scope. Okay, this is your level 2 scopy, wherein first you see the needle, okay, yes, this is the position of my second trocar, because second trocar may you'll have to put another some instrument to say, if you want to do a biopsy, you have to take a grasper or a biopsy forceps. Now you, instead of the needle, now you put in another trocar. Okay, you remove that needle, put in a trocar. Sharp trocar you've put. That now you can see the trocar coming in. See this? That is the trocar coming in. When you see the trocar coming in, then you remove this cannula. Okay, instead of that, you will put your either a biopsy forceps or whatever. Suppose you want to do this, that sharp thing is out. Okay, and you wanted to cut that, right? So you put in your scissors. You put in your scissors through that second trocar and you cut the fibrous band. Okay, this is your level 2 complete. If you want to say take biopsy, if you say see something that shouldn't be there, you want to take biopsy, put in a biopsy forceps. That is your level 2 complete. Okay, so one is the scope, and the other is just, so there is one more. There is one more this thing, one more trocar. Okay, so two trocars in level 2. Now this we have done. Now level 3. Level 3 is again, quickly I'll show you. Level 3 is with the scope, when you put one more trocar. Okay, you already have 2 trocars. With the third trocar, you will go in. I don't think that's enough. Now there's more time. But with the third trocar, you will go in and you will tie the disc. All these videos are there in the book, in the textbook, in Gary sir's chapter. The videos are attached with that. Or I think Nehal has put all these videos on YouTube also. Okay. Basically, what you're trying to do is go in, take a suture through this, take a suture through the disc, pull it back and tie it on the skin. Okay, so there are 3 in that tiny thing. There is one trocar, there is another trocar, and there is a third trocar. Okay, 3 trocars have to go in. That will be your level 3, and you will do a level 3 discopexy. I really don't have time to go into details of this. Okay. Okay, now this is synovitis, but this is extreme inflammation. This is what you will see on the scope. Okay, so this is retrodiscitis. Now retrodiscitis, now it is so bad generally that either your pseudo disc formation will take place or the disc may perforate. Okay, so this is a perforation in the disc. All right, then you have synovitis, capsulitis. So again, this is retrodiscitis. Now these are adhesions. See this? These are all adhesions that they are making the disc stick. Now here there is a small disc perforation. See the condyle here? This is a disc. This is the condyle which has perforated through the, which you can see because the disc has perforated. Now this is a large perforation. Okay, the disc, this is part of the disc, this is part of the disc, and this is the large perforation through which you can see the condyle. Now this is again synovitis, but it's a villonodular kind of synovitis. Okay, it's bad synovitis. These are polypoid synovitis, and then this is like really bad. Okay, everything is all completely gone. This is like grade 4 chondromalacia. The entire disc, whisk, everything is gone. And therefore, if it's a grade 4 chondromalacia, grade 4 degenerative joint disease, then we will not go into detail, but there is this, there is the glenoid component, the fossa component and the ramal component, and the entire thing is called a TJR, or a total joint replacement. Now quickly, we'll just finish subluxation in the next 3 minutes. So we know what subluxation dislocation is. It is going beyond, the condyle is going beyond the eminence. Now we know how acute therapy you have to put this thing back. What is new is the only thing I'll be discussing. So new, relatively new is these things, right? What are the non-surgical things that you put inside the joint so as to cause a constrictive or a sclerosing effect? So this STD, sodium tetradecyl sulfate, is what we used to use when we were doing our MDS like some 20 years back. But prolotherapy with 10% dextrose, PRP, IPRF, and autologous blood injections, these are the things that have really caught up. So there are n number of articles all over the place. So there is again dextrose that we use, and then there are long-term studies also that say that no, at least on the MRI, there is no fibrosis, and there are no bony changes that have taken place because after putting blood or dextrose. Okay, but then they say that blood is superior to dextrose. These are a couple of studies in By AOMS. Now between PRP and PRF, they say PRF or IPRF is better than PRP because it significantly causes reduction in pain. We also compared. We've published I haven't written the other one, but we've published a study on arthrocentesis followed by blood, and we found that to be very useful. But we did only MRI studies, and in the MRI studies, we did not see any fibrosis or any ankylosis or any so neither any bony injury nor any soft tissue injury. Everything was intact on the MRI. There are other MRI studies also that say that yes, there is some amount of hematoma, but no fibrosis. Now these were the injections. Okay, now for the surgical procedures, we know that either we can do without entering the joint, we can either only do capsule tightening procedures, or if you're entering the joint, then we've always known about Daugherty's procedure, wherein we cut the arch and then put it in a new position in such a way that it restricts the further movement of the condyle. So these are various modifications of Daugherty's itself. Then there is something known as a glenotemporal osteotomy. So basically, it's just a kind of an oblique osteotomy through the eminence and put it down. So that will interfere with the movement of the condyle. So either just osteotomize it, partial osteotomy, and push it down, or you put in a bone graft here also. So that is the other modification of that. So either that, or then you put in, say, bone plates, an L-shaped or a T-shaped plate or a screw or some sort of bone graft there, or do myotomy, so a lateral pterygoid or a temporalis myotomy, all of this. Remove the condyle or remove the eminence. Now, this is something that we've always been doing, I think, eminectomy for subluxation, but where a lot of people go wrong, and this is really important, is that, a lot of people only do the lateral part. They remove only the lateral part. So that is known as just an eminectomy. Whereas where only this part is removed. Whereas true eminectomy is when you go right deep down till the medial part and remove that entire thing. That is true eminectomy, because you'll feel that I did the eminectomy and the patient is still dislocating. The reason is that you've not removed the medial part. 1 hour complete. So eminectomy plus discopexy is now the next big thing that they're doing. Why leave the disc alone? Because it's not just the condyle that has moved forward. It is with the condyle, the entire discocondyle unit has moved forward. So not just do the eminectomy, but also pull the disc back and suture that to the using these screws. So this is Yorkshire, and Andrew sir has published this. So he put 2 screws here, took 2 sutures here through the disc, and through the screws put the sutures. And then now the latest in this is something that I've borrowed from a friend. This is Vikram sir from the UAE. So what he does is, so no, this is our case. So we go into the retrodiscal tissues and then inject blood directly into that. Okay, directly into the retrodiscal tissues, we inject blood instead of injecting it just into the joint. Okay, so that is one thing. And then this is what I borrowed from Vikram sir. What he does is he takes a laser and then just burns the retrodiscal tissue. So that causes contracture of the retrodiscal tissues. So the disc comes back. Contracture of the retrodiscal tissues pulls the disc back. And then you can always do a discopexy, pull the disc back, and that will take care of so all the lax ligaments, they become tight because of the disc that is pulled back. So these are the kind of latest things that can be done in derangement. Now, just quickly, last 1 minute. See, initially, okay, let's go here. So basically, we need to figure out what is the difference between myalgia and arthralgia. Where is the tissue source of pain? Is it the muscle or the joint? Now, the problem here is that they are not mutually exclusive. There can be ID, arthralgia, and myalgia. Okay, so the pain may be perceived in the joint, but it may coexist with myalgia, and that can be confirmed with muscle tenderness. Okay, now the only problem is it is very difficult to ascertain whether the MPDS came first or the joint pain came first. Whether ID comes from MPDS or MPDS comes from ID. It's very, very difficult to figure that out, what came first and what caused what. But there are so many of these examples, bruxism. So a lot of times bruxism can cause MPDS, but then because of continuously moving the jaw forward, there can be problems in the disc as well. Because there is, in another case, if there is mandibular prognathism, because of the prognathism, it can lead to disc issues. And then because of those, and because of the prognathism, it can lead to MPDS also. So all of that, subluxation. Now, subluxation, because the joint is, the whole joint is moving, the whole condyle is moving forward. It is taking the disc also forward and taking the disc also forward with it. And in such a situation, because everything is moving forward, it can cause MPDS also. A condylar head trauma, again, because the head is not in the right position, because the muscles therefore are not in the right position, it can cause ID. Because the muscles are not in the right position, it can cause MPDS also. So, that is the relation. So please understand that it may not necessarily only be MPDS or only be ID or only be subluxation. Even in a subluxation case, please look for disc changes. Please look for muscle issues also. If only you cut off the eminence for a subluxation case and the patient comes back to you with pain again, please understand that maybe it is the muscle issue that we have not thought about. So therefore, Mahan's test or the diagnostic block, all that is absolutely essential to have a correct diagnosis. So you have to have the complete correct diagnosis. You have to treat the complete profile, not just a partial profile. Oh, the patient is opening his mouth 55 mm, subluxation, okay, post for laminectomy. Forget about everything else. So now there is a TMJ questionnaire. I'll give it to Akhilesh, I'll give it to you and maybe you can put it up on the group. There is an entire questionnaire that was initially made by Gary sir. Then there were certain changes made by Nehal, a few changes made by us. So we follow that questionnaire. We get the patients to fill up part of that form and then the rest of the form we fill up. Once you fill up that form, then you know for sure, okay, everything has been taken care of. We've not missed anything. So that is very important. Again, I'm not going into too much detail, but we see that, if clenching can cause MPDS also and ID also. Bruxism also can do this, but clenching can cause a maximum of TMJ ID symptoms also. Okay, there is both clenching and bruxism. Again, MPDS and ID can both be caused. Again, Botox is used when combined with Scopy for the treatment of concomitant arthralgia and MPDS. So there are things where all of these coexist. Now, just the last couple of slides. See, why is history taking that? Just 2-3 cases, why is history taking so important? So this girl, she's I think 2022, she comes to us.
Sonal, can I just
I'm done. Yes,
yeah,
yes,
okay,
I'm done.
Good. Because there are a lot of questions in the questions.
This is just 2 cases where it's just telling you why this is important. I know it's like 7 minutes post mind. I'll just finish quickly. So this is very important because she came to us with ID and subluxation and MPDS, everything. So we did Scopy, we did arthrocentesis, we gave blood, did Scopy, but then there was no relief. So then, later she says, okay, one day she says, oh, I am perfectly all right. And then what happened? that she had been sexually abused when she was a child, and that man met with an accident and he went into coma, and then suddenly all her stress and everything got relieved, and suddenly she comes back to us and says, okay, now I'm fine. So that is the importance of the psychological part also. And then this lady was treated for, she had a past history of TB, treated for 5 years with only MPDS. But and then when we saw the CT, they said, okay, it's a granulomatous lesion. But then they said without an actual biopsy, we will not be, we cannot start AKT. So then this was probably my first or second case of arthroscopy. So this is not very clear, but this is something that I've taken from the net. This is what it looked like, okay? So finally we realized when we went in, because we did an open joint surgery, and then this was the result. This was synovial chondromatosis, but we figured out only because we did a scopy and we saw that yes, there were things. So we need to learn scopy also. And this is the last slide wherein he had subluxation, we put in blood. Now again he has subluxation, and again he has pain in the joint, and he has MPDS, and like, what do we do now? So we did a scopy and we saw that the joint looked absolutely terrible. Okay, this is really a bad joint, and the reason, and the MRI is all clear. Okay, there is ID, but the MRI is, otherwise you do not see all of this fibrosis at all. So this just leaves a question whether we should be, actually on MRIs and so many studies, they say that there's no problem, no fibrosis. But I think if we're blindly putting in blood and dextrose and whatever in cases, we need to know what is really happening inside the joint as well. That is pretty much all. I hope, we've discussed all of these things, and we just need to know that please rule out all the causes, make the correct diagnosis, only then plan the treatment. Thank you so much. 9 minutes extra.
Thank you, Sonal. Can I jump into the questions, please?
Yes, I will just stop
Dr.
sharing.
Shavani was asking whether you could tell her the dose of indomethacin that can be given.
Okay. I do not know this because my PG is prescribed. I will just ask
Dr.
them and let you
Shavani,
know.
I think it is 75 milligram. You can give 75 milligram extended release tablets a day. I hope I have answered your question.
Yeah, I guess.
The next one is by Dr. Teresa. How is the auricular temporal block given? Do you want to tell her, or would you like to ask her to refer a book? I think it is.
Yes, that would be better. We open the mouth and go inside the joint actually, but you need to refer to a book for that. And it's
Dr.
given,
Teresa, it is written very well in all the textbooks, especially in Dr. Warburton's chapter in the AOMSI book for the clinician. It's a wonderful chapter, like Sonal had mentioned. The two chapters, the one by Dr. Baig and the one by Dr. Warburton, are really classics. And this doubt is sure to be solved once you read those chapters. Dr. Sujesh Viswanathan, he's just flooded the chat box with questions. I think we can go over to his doubts. He has asked, ma'am, is it advisable to infuse steroids to the joint post lavage, as some article states that it increases the fibrosis in time? Can you answer him, please?
Yes, no, everywhere, and for a number of years we've always all been saying that no, we cannot use steroids because that actually causes degenerative joint disease. You can only use a total number of steroids is one time, and that too it is preferable if you actually see when you are doing a scopy. That's why I keep saying scopy. Please, everybody learn scopy. You see the thing exactly into that area where there is synovitis, you inject directly into that area only once. Full stop.
Sonal, I was just wondering, what we do here is we give a steroid wash soon after the arthroscopy or the arthrocentesis, and then we just wash it out, because our classic teaching always tells us that steroids ultimately cause bone erosion. So what we do here is we reserve the steroid wash only for very old patients where already there has been some kind of bone erosion that you can pick up on the radiograph. In a fresh joint where not much of bone erosion has happened, I would reserve it for
the
later.
Steroid, yes.
What do you feel?
So in a joint that's already damaged, all that you will do is maybe damage it further. The positive effect would be you would probably be giving him some amount of pain for some amount of time, nothing else. So why do you want to worsen that condition?
Yeah, I would say that we can reserve it for a badly damaged joint, and if you want to give it for extreme pain, you can wash it out soon after you do your steroid wash. Am I right, Sonal, or would you want to say something more?
A badly damaged joint is how many months would you really pull it, more with just one steroid wash? A badly damaged joint
like,
needs a TJR.
yes,
So
yes,
yeah,
it does.
maybe
But for
some
an
amount
acute
of time.
condition,
Yeah. Okay.
yeah,
Yes.
yeah, you can buy time. Am I
Buy
right?
time. Yeah.
And
Okay.
Sujesh has asked the next question. And ma'am, do the impacted lower molar tooth has to relate anything with the joint movements with clicking? And if that's so, post disimpaction, do we have some splint for post correction?
That was my first point. Please do not overestimate the importance of a third molar in causing joint pain. But please do not underestimate the importance of a third molar disimpaction surgery in causing joint pain. Okay, so if it's just lying there, class 3 position C, don't go inside and remove it saying that, oh, this might be a possible cause for your pain. That's not it. But if you go in and remove it, then yes, you take those 2.5 hours with the mouth open, with the joint which is already partially damaged. The next day you are going to have major problems with the joint. So,
and would you suggest
I hope
splint?
that answers.
That is what. Yeah. What about your take on splints? What do you advise?
No, so splints, all that splints do is they give you temporary relief from the pain. That is all that they do. There is nothing else that they do. That they will reposition the disc and this, that. All that is not going to happen with splints. And especially if you're talking about a disimpaction surgery, nay, a splint will only, if there is acute damage to the joint, it will only disocclude and give you relief from pain. It won't do anything else. So if there is a TMJ issue, do not go in and do disimpactions, please.
Sonal, I was wondering, after your level 1 arthroscopy or arthrocentesis, do you routinely give a splint for some time, say for 3 months, to make the patient more comfortable?
No, so all that the non-surgical aspect has to be finished before you do a centesis or a scopy, basically. That comes under the conservative part. So the minute patient comes in and if he's not had any treatment at all, 3 months is what you do, how you treat him conservatively. 3 months is max. Say 2 to 3 months conservative, which includes your splints, which is if there is an acute pain, it will just get rid of the acute pain or hold it temporarily. After that, you have to go in and find the definite. That is why arthroscopy is so much better than centesis, because you are actually seeing what is wrong with the joint.
So you don't give splints after your scopy or your centesis?
Before,
all right.
Not after.
Before, not after. Is there anything against giving a splint after your scopy or the centesis?
There's nothing against it. No, but it's not going to serve any purpose, na? That's why you do what the treatment has to be based on the diagnosis. The diagnosis is there is acute pain. Yes, you give a splint to get rid of the acute pain, because in an acute joint you cannot enter. Na? So conservative till you get the acute phase down, then go in with your scopy. And after that, there is no scope for your splint to do anything.
Splint, okay. Because what we do here is, after the centesis or a level 1 arthroscopy, we advise the patient to go in for a splint.
And what does that do?
Give them some kind of relief. So
the relief should be because of the arthrocentesis or the scopy.
Probably, maybe. But I was wondering whether is there anything against splints after scopy? Okay. Okay, good. So the next question is by Dr. Jnanis Sagar. What could be the best treatment for 1-year-old bilateral TMJ dislocation?
That I've not touched here specifically, because we were not talking about that in detail. But then it would probably be some sort of orthognathic procedure only. Either do a midline osteotomy, and both those things separately you reduce and then put this thing back. If it's that old, it's probably not going to respond to anything.
Good. Next one. Can I go to the next question?
Yes.
This is by Dr. Arun. Ma'am, what's the role of splints in both MPDS and ID? I think Sonal has answered that. And there are fantastic books to read on books on splints. There is one by DuPont, if I'm right. Then there are lots of wonderful books. And Dr. Baig's chapter has a nice reference list. So the last reference is specifically for splints. It's a wonderful book. Then Dr. Sujesh, again, he's come with another question. Ma'am, does this architectural changes of condylar head with thinning and J-shaped pattern with dislocation can be managed with synthesis?
See, synthesis, I'll tell you. The thing is, once you do synthesis, and if the patient doesn't have relief, that is the end of the line for you because you don't have any further information, right? Whereas if you do a scopy, you have looked inside the joint, you know what exactly is wrong, so you know what the next line of treatment is going to be. So that is the difference. So synthesis is really, I mean, if you're not trained in
at that
scopy,
point,
then yes.
Yes, I agree with you, Sonal, because at that point, synthesis doesn't really work. You're right.
Yes.
That is great. That's true. And Dr. Ashi, thank you so much for putting in the answer for the first question. Thank you so much. He's answered it so clearly about regarding indomethacin, the dose. Thank you so much, Dr. Ashi. Thank you so much. Sonal, I had a lot of questions for you, but I'm afraid
I'm sorry.
Everybody's flooded you with so many questions. I think I need to talk to you alone if I have to answer all my questions. I guess, lots of compliments coming for you. Dr. Dr. Yashasini has said something. One wash of steroid does not trigger the erosions. Multiple injections into the joint as a symptomatic treatment is concerned. Yes, I agree with you. But I wouldn't take a chance. Even with one wash, I wouldn't take a chance. That's why I always wash it out soon after I get steroid. Probably, yes, I agree with you. Many repeated, yes, you're right. And Dr. Dinakar Reddy has asked another.
Even in our because I've done this TMJ mini residency where we have like the world's top TMJ surgeons who teach us. They also say that one is as far as you go, and best is when you actually see the through the scopy you actually see where the synovitis, where the inflammation is, and directly into that you give that, and that is it. Don't give anymore.
Dr. Dinakar has asked this question, ma'am, that means all symptomatic patients need to go for scopy to come to a definite diagnosis. Would you answer that?
No. So see, it starts with history and clinical examination, right? So based on that, you go further. Then you do your MRI. Based on that, you go further. Then you do your level 1, and then you will, that is how you go. So and a lot of cases will probably get sorted even before that. And level 1 is 85% of your cases will get sorted at the level 1 stage. Only say 5% of cases probably need a level 3, So so once you have your correct diagnosis, and if you think that, okay, this much only is the problem, you can do arthrocentesis. And if you get relief with that, that is fine. The problem, as I said, with arthrocentesis is if you do not get relief, then where are you left with? What are you left with? Your MRI is not going to tell you anything more.
Exactly,
that is the reason you need to do scopy.
So this is a forever argument between my esteemed colleague Dr. Bobby John, who's an expert in scopy. He is a guy who bats for arthroscopy all the time, and I'll say it's arthrocentesis. Do it first. Then he says, no, I have to see what's happening inside. So yes, Sonal, I agree. This is for the forever chicken and egg debate. Which is better.
What? It's not really difficult.
Yes.
It's and now we're trying to start a lot of other, like my Gyan, we had the scopy sessions. We're going to try and do many more now. So I am very happy to train more people in scopy. Nehal, Pramod, we're all together. We'll try and train more people in scopy as much as we can. Even level 1, if you do, it is like seriously 85% of your work is done. You have you have to do scopy.
Before you go into do a scopy, I think you should be masters in doing an arthrocentesis, because it's basically that's the
it is that.
First do your synthesis and then go in for a scopy. Otherwise, I don't know how.
And
I think your learning curve is going to be very much steeper. So,
yes, and Deepthi, you need to do open joint surgery first before you do a scopy, because if you mess up in the scopy,
definitely.
If there is bleeding, you don't know how to open the joint, then so yes, synthesis, open joint, and then come to scopy. Yes.
Yeah, there's one question from a very intelligent PG of mine, Dr. Payal. She was asking you whether she wanted to ask of various agents used in prolo and sclerotherapy, which is most preferred. So would you have something to...
Dextrose 10% is
Yes,
what is
yes.
used most of the time.
Yes. In
But they say
fact,
blood is
yeah.
better.
But I have
So-
read articles where they say that blood causes erosion. I don't know. I have read a couple of articles. So I would be rather, cautious of going on blood.
Erosion, maybe not, but I have myself seen at least 3 cases now wherein after giving blood, we've had to do scopy and the joints are looking horrible. Trust me, I
they
showed you that
fibros.
joint, right?
Yeah, a
It
lot
is
of
so
fibrosis.
bad.
Yeah.
And you
Yeah.
can't, because there is no published literature on that with on scopy after blood. There are a lot of studies there are of MRI after blood. And MRIs won't show fibrosis, they won't show adhesions. So these are like really bad joints, So I don't know. I'm now kind of thinking maybe I should not be putting blood for all those cases.
Yeah. So I guess, Sonal, I reserve my questions for you later. Thank you so much.
Thank you.
It was a
I'm
very
sorry for
elaborate
it. Just
presentation.
so yeah,
No,
it's
but there
just so
is.
long, so I had to kind of
No, I don't think anybody would
take
blame
extra
you for
time.
that, because the more we learn about the joint, the less we know. That's what I have to say. We always left with the whole bag of doubts. Thank you so much, Sonal. Thank you so
Thank
much.
you so much for having me. Thank
Thank
you
you
very
for coming
much.
over for AOMSIKerala. Thank you, Akhilesh and Dr. Akhilesh and Dr. Anand. Thank you for this opportunity. And to all the
Thank you.
participants who've joined, taken their time late in the night. Thank you so much. Good night.
Thank you. Good night. The questionnaire, I will give it to you. Maybe you can put it in your Kerala group or something.
Yes, ma'am.
Definitely,
Yes, ma'am.
definitely.
We'll do that.
Yeah, I'll
Thank you
send you
so
the
much.
questionnaire. Okay,
Thank you
thank you
for
so
a
much.
wonderful presentation, ma'am, and for moderating the
you.
session, Deepthi, ma'am. Really wonderful. I think we have 5 minutes left. If anybody wants to ask any more questions, I think ma'am is
Sonal,
tired.
I
Oh,
have.
then let me.
I don't.
I
let
have.
me.
Yes,
Do
please
you
go ahead,
want
ma'am.
me to? Do you want me to put this here? That questionnaire.
It's
Ashi,
all
if
right.
you are
Yeah,
here, maybe.
Sonal, can you take a question?
Okay.
Can you take
Yes,
my
yes,
question?
please. Please.
Sonal, how much do you go into the joint when you do a scopy? What is the maximum length you go in with your trocar?
20. So we try for 20, between 20 and 25. 25 is the max. It's between 20 and 25 always.
Yeah. That is what I wanted to know, because Dr. Bobby at GDC Kotem, he goes in 25 mm. So that is what I wanted to know, whether we should, whether we can, whether, because he always says, I can go 25 mm. So that is something that I really wanted to know. And what are the precautions that one should take if you don't want to enter the middle cranial fossa when you do a scopy?
Yeah, so the way you hold the trocar, the sharp trocar, that is one. So the force shouldn't be directly like this. It has to be swiveling and slow like this. And then when you touch the inferior border of the arch, then it is the left thumb that has to push it down. So the amount of force that you use with your right hand, that is much more than the left thumb. So once you touch the inferior border of the arch, after that the force becomes less because you're using only your left thumb to push it down. So that way, then with so much force, you will never enter the lymph. However, there are still chances that you can. Don't worry about not entering. It might happen to the, but yes, these are two things. These are two things. One is swivel, piston in, and two is use the left hand to finally go inside when you're near the glenoid fossa. Those are two
One
ways.
more question for me. Thank you, Sonal. Thank you so much. Would you prefer eminectomy or the daughtry procedure? What would you like to do if you're faced with the case of subluxation?
Okay.
What would you
Daughtries, I
prefer?
think daughtries used to be, I would rather do a glenotemporal osteotomy. But having said that, I don't know, we are doing eminectomy as of now, which we are now going to which we are now changing to eminectomy with discopexy. So I think neither of those two, eminectomy and a discopexy, would probably be better.
Okay, thank you, Sonal. There's one question from another student from Kotem. When do you consider inferior joint arthroscopy? Dr. Shanmuga Priya Ganeshan has asked this question. When do you consider inferior joint arthroscopy?
I don't know if we can do it. I really don't know, because in all this time, I've never heard of anybody doing an inferior joint scopy.
Okay. That's good. Okay. So thank you so much. I never expected so many people to be awake at this time. And it was a fantastic presentation once again. Sonal, thank you so much.
Thank you.
Thank you. And to all the participants.
Thank you so much for having me.
Good night.
Thank you.
Bye-bye.
Good night.
See you.
Good night.
Bye.